Assalamu alaikum, good morning. Uh, Today our topic of presentation still revolving around RCC, localized disease management. The active prevalence has been discussed beforehand. So today we will going to discuss some other maneuvers other than partial and radical nephrectomy in this session. So yes, Dr. Bikalpa, please start.
Good morning, everyone. Today, the topic of our discussion is management of the localized RCC, and our learning objectives will be radio frequency ablation, cryo ablation, and microwave ablation. Now, introduction. The average size of RCC at presentation is decreasing, and more patients are presenting with small localized lesion because of the widespread use of the cross-sectional imaging. Perspective regarding clinical T1 masses have changed substantially in the past 2 decades. In a sense, all were presumed to be malignant and managed aggressively mostly with the radical nephrectomy. But nowadays, because of the recognized great heterogeneity in the tumor biology, multiple strategies are available, like radical nephrectomy, partial nephrectomy, thermal ablations, and active surveillance. Now, today we will be discussing regarding the thermal ablations.
What are thermal ablations? नाम से कुछ thermal related to, yes, Mariam? Yes, as name suggests, it's a kind of a technology which uses a heat in one form or other. Even in the high side of temperature or low side of temperatures are used to induce apoptosis of these renal mass cells, and which lead to ablations in long-term follow-up. So these are known as thermal ablations. There are many kind of thermal ablations which have been studied in the past, and there are many which are still in process in future. But we will discuss only with a few one which are mentioned in your guidelines and your books. The basic thing is that you don't need to know about the detailed process of how this should be performed in a patient. But yes, the basics and what is a mechanism and what is a pathophysiology by which it causes a tumor cells to ablate should be known. Yes, Vikalpa.
Now, thermal ablations, including cryosurgery and radiofrequency ablations, are now established as an alternate nephron sparing treatment for patients with localized RCC. These techniques can be administered percutaneously, laparoscopically, and via open surgical techniques. And the morbidity profile for thermal ablations proved to be favorable than partial nephrectomy, according to the meta-analysis associated with the guidelines. And its effect on the renal functions are limited, and the renal mass biopsy is prerequisite.
Now, pertaining to renal functions, some studies said that they are absolutely indicated in those in which patients are already labeled as CKD 2, 3 or EGFR less than 45 mils. They are absolutely indicated. But there is no absolute indication that has been proved so far. Some studies indicate, but some studies said that there is no absolute indication of performing these kind of ablations. Yes.
Some evidence showed oncological outcomes of thermal ablations also based on histological subtypes of RCC.
Any idea which subtype is more responsive to these kind of thermal ablations and why?
And thus influencing the decision-making process. In a series of patients with clinical T1 disease with a mean diameter of tumor 2.5 centimeter treated with a radiofrequency ablation, 5 years disease-free survival rate was 90% for clear cellular RCC and 100% for papillary RCC. And other emerging ablative technologies include stereotactic ablative body radiotherapy and non-thermal irreversible electroporations, which we will discuss shortly in next slides. And the optimal applications of this technique requires intervention radiologist and urologist who are experienced and skilled in these technologies. The increasing acceptance is based upon favorable outcomes in initial studies, which includes a low incidence of serious complications, less immediate morbidity than with surgery, lower cost, and ability to treat patient in the outpatient settings.
Well, I don't know about the cost setting, but as far as I know that the original technology which led to the fine probes and reusable probes cost a lot. Number one. High degree of supervision is required for these process, number 2. And number 3, we will discuss the morbidity and side effects, specifically complications in coming slides. Yes.
Patients should be counseled regarding the need of multiple treatment sessions because of difficulties in monitoring the extent of ablation, particularly for tumors greater than 4 centimeter in diameter. And it may not be appropriate for larger lesions or tumor near the hilum. Now, indications. The clear indication for radiofrequency ablation or cryoablation to treat RCC have not been definitively established. However, factor leading to consideration over surgery includes a small incidentally detected RCC, ideally less than 4 centimeter in diameter, limited to the kidney. A patient who is considered a poor surgical candidate based upon older age or significant comorbidities. A patient in need of nephron-sparing treatment to postpone or avoid the need of chronic dialysis, such as the patient includes the patient with already a known case of chronic renal insufficiency, a single kidney, bilateral RCC, or a genetic predisposition to multiple tumors. Example, von Hippel-Lindau syndrome. And these techniques can also be used in those patients who have a local tumor recurrence after nephrectomy, who have intractable tumor-related hematuria, tumor debulking in patient with metastatic disease, or in the management of symptomatic distant metastasis from a primary kidney tumors.
So it can be used as first line as well as secondary line in the management of this localized. Most of the literature and book says that the maximal size should be less than equal to 3. But since Steve encompass all the tumors which are up till 4 centimeter in the kidney, so we can also consider this as. Yes, Vikalpa.
For patient with one or more of these factors, these techniques may be an attractive option since ablation may avoid the morbidity of surgery while offering an effective and potentially curative treatment options. Now,
Okay, sorry, I'm interrupting. Any other organ in urogenital system in which you have ever read about involvement of this ablative techniques? Yes, prostate. Good. Chalo.
Now, patient selections. Pre-treatment imaging is used to define the extent of disease and presence or absence of metastasis. And pre-treatment imaging can be performed with ultrasound, MRI, or computed tomography, CT scan. And patients should be evaluated by both a urologist and radiologist prior to treatment. And a pre-treatment biopsy, as I already mentioned, should always be performed, as imaging does not accurately differentiate benign from malignant disease. And tumor size and locations are the most important factors that govern whether RCC can be successfully treated or not. At least 0.5 to 1 centimeter ablation margins surrounding the tumor is needed to ensure that the tumor is adequately treated. And since temperature gradient exponentially decreases with distance from the radiofrequency or cryoablation probe, large tumors pose a significant challenge. Tumor less than 4 centimeter is ideal. Most tumors less than 3 centimeter can be treated in a single session, and the tumor between 3 to 4 centimeter in diameter can also be successfully treated. However, multiple ablations may be required. The exophytic tumors are most amenable to ablations since these are surrounded by a heat-insulating perirenal fat with relatively little vascular tissue. So they are more resistant to heat sink effect. And the large exophytic tumors as large as 4 centimeter are almost always successfully treated, with 70% or more requiring only a single session. Parenchymal tumors may be more difficult to treat, and the centrally located tumors are hardest to successfully ablate due to the heat sink effect. Basically, the heat sink effect is a phenomenon in which the effectiveness of the ablation is decreased when the tumor is in proximity less than 1 centimeter away from vessels which have more than 3 mm of the diameter. Then the blood vessels with drawn the heat and has a cooling effect, thus decrease the effectiveness of the ablation. This is called the heat sink effect. And the central tumors are hardest because of the heat sink effect to treat.
Another thing, centrally located tumors are also hardest because if we proceed towards the central part of the kidney, we will obviously moving towards hilum and great vessels. So there are many techniques which are modification of this radiofrequency ablation, which we will going to discuss shortly, that can be applied in those tumors that are located in the central part of the kidney. They are one of a modification of radiofrequency ablations. Okay. So it's not an absolute contraindication, but other modifications are also present, and it's avoided in most of the times because there are side effect profile of the centrally locating tumors which are treated by this ablative therapies are much more. Yes, Vikalpa.
Now proceeding towards the contraindications, the relative contraindications include life expectancy less than 1 year, the presence of distant metastasis, and the tumor more than 5 centimeter or tumor near the hilum or central collecting system. And for tumors in which treatment may cause thermal injuries like urine extravasation or urinoma, an intraureteral stent is inserted prior to the treatment. And the absolute contraindications include irreversible coagulopathies or severe medical instability.
A very big indication of these thermal ablation therapies is a patient's will, patient wish. Okay. There are some patient literatures mention that they do had metastatic diseases at the time of presentation, but they want to cater only their tumors, which is located inside the kidney, biopsy proven RCC or any other thing. And in that scenario, we have to follow those patients very vigilantly, 3 monthly, 6 monthly, and even the recent studies also document that if in case of a metastatic RCC, if the primary mass in the kidney can be removed by this ablation technique, then the effect of adjuvant chemotherapy is much more. There are few studies which are under the process. Okay. Yes.
Now the choice of the ablative techniques. Basically the choice depends upon the operator experience and comfort, and which helps in the determinant which is the most important determinant for achieving a good outcomes. Many interventional radiologists prefer radiofrequency ablation, and many urologists prefer cryoablations based upon local familiarity with a given technique. Both techniques demonstrate a very high efficacy with limited complications, which has made a direct comparison challenging. The ability to conduct a randomized control trial comparing this treatment approach is limited, since the number of patients needed to demonstrate a significant difference is too high to be feasible. And then next, the preliminary outcomes for microwave ablation therapy have started to accumulate, demonstrating high efficacy, but further evaluation and follow-up is required. Until then, the choice of microwave technology is also based upon operator comfort and experience. Now, procedure. The most commonly used thermal ablation techniques are, as I already mentioned, radiofrequency ablation, cryoablation, and microwave. Other techniques such as high intensity focus ultrasound show some promise, but are not widely used outside of experimental setting. This is also a newer technology, and in this technology, high intensity sound waves are delivered to the tumor and sparing normal tissues. The main advantages are these techniques are radiation free, and it has high efficacy and can be treated in outpatient settings also. And both the techniques can be percutaneous approach is generally preferred over laparoscopic and surgical approaches, and are usually performed on outpatient procedure unless comorbid conditions require hospitalization or closer observations.
But in radiofrequency ablation is usually performed under general anesthesia, and a patient do require a stay of at least 24 hours post-op. Okay.
Can be performed under local anesthesia or conscious sedation is typically required. But however, some clinicians and patient prefers general anesthesia, and it can be done on supine, prone, or lateral decubitus position. After the local anesthesia is given, the applicator is percutaneously advanced into the center of the tumor under CT, ultrasound, or MRI guidance. Then the extreme heat or cold is then applied for approximately 5 to 20 minutes, as dictated by the device maker's recommendations. Now, depending upon the size and location, readjustment of the applicator may be needed, or multiple applicators can also be used simultaneously. Post-operatively, the patient is monitored for several hours and can be discharged home with oral analgesics for post-procedural pain. And patients usually are able to resume full activity within a couple of days.
Basically, these applicators are small probes. that are applied through the skin, and then they delivered the desired or the required radiations or electromagnetic waves or heating phenomena or cooling phenomena. Okay, so these applicators are small probes. They are reusable as well. Okay, proceed.
And the laparoscopic approach is similar to other surgical laparoscopic procedure requiring GA. However, the image guidance is limited to the small laparoscopic transducer ultrasonography probe. Most patients treated laparoscopically are hospitalized overnight, and there may be a more post-procedural pain. And the choice of laparoscopy versus percutaneous approach is based mostly upon the local expertise. And laparoscopic ablation basically performed by urologist. However, percutaneous are usually preferred by intervention radiologist. And the anatomic locations of the tumor also influence the choice between the laparoscopic or percutaneous approach. Usually, the tumors located on the posterior aspect of the kidney can be treated with a percutaneous approach. However, those tumors which are anteriorly placed are usually treated with the laparoscopic approach. Now, the radiofrequency ablation. Radiofrequency ablation utilizes a high frequency, that is 462 up to 500 kilohertz alternating current to generate a heat. And the most radiofrequency system used for the kidney are monopolar, and the current is completed with the grounding pads placed on the patient back or thigh. And these thermal ablations radiofrequency ablation is delivered into the tumor through a thin needle of usually 21 to 14 gauge that is electrically insulated except for its terminal 1 to 3 centimeter. And this current produces resistive friction in the tissue that is converted into heat, analogous to the heat production from an electrical resistor in a circuit. The heat in turn causes membrane and cellular destruction and protein denaturation. There are various kinds of radiofrequency applicators that are multi-time applicators, cluster applicators, and pulse energy delivery.
The maximum temperature required to achieve the radiofrequency ablation is up to 40 to 60 degrees centigrade in case of kidneys. Okay. Yes, Abhikal.
Now, this is a pictorial representation of the CT-guided radiofrequency ablation procedure. In the first image, we can appreciate a small renal mass placed anterior to the kidney, which is depicted by the yellow arrow. And in image B, the pneumoperitoneum is partially created to avoid the other tissue from injury. The air is injected to make a plane. The normal saline can also be used to displace the surrounding structure to prevent it from the radiofrequency ablation injuries. And we can appreciate a linear probe going into the tumor. And in the last image, that is a post-procedural image, and the tumor is completely necrosed after the therapy. Now, this is the same image in the coronal view, where we can see a tumor and the probe. Now we will see the short video.
Now we're looking at a small lower pole tumour which we're hoping to ablate just percutaneously. And here you can see on the ultrasound, that's the small renal mass there, and it's right next to a branch of the renal artery, which of course is going to try and take away the heat as we try and heat it up with microwave ablation. So that could provide a small problem for us. Here we can see it on a linear probe, and you can see the vessel right next to it quite nicely. We may actually do the ablation using a linear probe. Lift the probe a bit, that's it.
Short stinging cessation, that's local anesthetic, really. Let me know if I'm hurting you, sweetheart, and I can give you more local anesthetic, okay?
Transplant kidneys are always very scarred. That looks very good. It looks like you're right in the middle of it. Take it to the far side of it, just to the back. Yeah, that's perfect.
Hold it there or a bit deeper?
I would go stay just there. Happy?
Yeah.
Now look transversely as well. Turn your probe around. We'll just get a view in a different direction. Check we're right in the middle of it. There, you actually look like you're right in the middle, don't you? Okay, ready to ablate now. So we're just going to go for 60 seconds at 60 watts, and I think that should be sufficient for this small lesion. Okay, we'll press start. Let us know if you feel any discomfort. I don't think you will. And we'll just keep watching this, and we should see some gas formation very shortly. There you can see a little bit of high reflectivity, that's gas formation. Do you feel any discomfort?
No.
Good. So that's 1 minute 20 seconds we're going for, and we're going to stop there.
Suzanne, can you press freeze please on the ultrasound machine? Yeah, thank you.
Okay, and now just press start please on the machine, and we're just going to slowly withdraw the needle and ablate the tract.
We can appreciate that the needle is passing through the renal cortex into the mass, but
you feel any
we can also see
discomfort?
that it is nearby to so many important vital organs that needs to be catered for. Now you cannot appreciate this mass because it has started to necrose, and this can only be appreciated either on CT scans, where we can see they are taking out needle back and some heterogeneous areas within this mass, within the cystic structure, which was not present initially.
Okay, I think that's fine.
This has caused a necrosis of this material within the system, and this can only be definitely diagnosed using any imaging modality, be it ultrasound or CT. Okay, for the radiofrequency ablation, I would also like to add something. First of all, initially we have discussed that those tumors which are centrally located towards a hilum or pelvic calyceal part of a kidneys, they are usually contraindicated. Why contraindicated? Because so many vital things are related to the in that part of the kidney, pelvis, starting from the pelvis, there will be ureter, there will be hilum, there will be other structures. But radiofrequency ablation has other modification, which is also known as a cooling pylocalyceal flow. This is a process in which the ureter, which are basically specified for those tumors which are confined to the pelvic calyceal system, the RCC confined to pelvic calyceal system or any ureteric growth. What happens in this kind of a therapy, which is a modification of radiofrequency ablation, they usually pass ureteric catheter periurethral using cystoscopic approach, and then they keep ureteric catheter in the ureter, in the proximal part of the ureter. And then they inject the 5% dextrose water, which was initially cooled at extremely chilling temperature. So that chilling temperature also denatures protein. And how chilling temperature denatures protein, that is same as that we will going to discuss in cryosurgery. So this is one of the way to target those tumors that are located inside the kidney. Okay. Then and another phenomena is that radiofrequency ablation is less reliable as compared to cryofrequency ablation. Why? Any guesses? Anything? And how can we monitor it? Like if the patient has expertise, if the urologist or radiologist has expertise, okay, then koi galti nahi hogi. If the doctor is not having expertise, then how monitoring can be done? There are bowels, there are chest, lungs, pleura. How can it be protected? There is no such system to predict the heat penetrance into the surrounding tissue in the case of radiofrequency ablation. But we can predict this heat penetrance in the case of a cryosurgery. This is one of the reasons that radiofrequency ablation is less studied as well as less recommended in international papers. Okay. Yes, now cryoablation.
The cryoablation can also be performed percutaneously or lap assisted with a success rate of more than 95%, and oncological outcomes are favorable for CT1A tumors. The liquid nitrogens or argon is introduced into the probe in a controlled fashion, and it results in the freezing of the surrounding tissue with the formation of an ice ball that can be visualized in real time. The intracellular ice crystals disrupt the cell membrane and other intracellular activities, leading to cell death. And the cells that are not directly killed may undergo apoptosis.
Maximum temperature which is required to do this process is minus 19.4 degrees centigrade in the case of a kidney. Liquid nitrogen requires temperature up till minus 100 degrees centigrade as well. But again, the cryosurgery, it depends from tissue to tissue. If it's meant for the kidney, the maximum temperature that is used for this process is minus 19.4 degrees centigrade. Okay. And anyone can please discuss the phenomena of how this happens? Cryosurgery. Anyone? कुछ भी फ्रीजिंग थॉइंग कुछ भी बता दो माइक पकड़ो बस Dr. Vikalpa, can you tell us, please?
A typical cryoablation session involves freezing, thawing, and refreezing.
So, what happened with this freezing thawing phenomena? What happens in these two steps?
In these steps, first we will freeze the tissue, freeze the tumor with extreme temperature, and ice
What
ball
happened with this freezing?
in the freezing. It may there will be an intracellular crystal formation in the tissue, and which mediates the cellular and membrane destruction, and the intracellular activities of the cell is also disrupted.
You know, what is the principle of cryosurgery? Principle of cryosurgery consists of two steps, which are done in successive portion, time and time again in a single setting. What happens is that we have to freeze the tissue till minus 19.4, and then the specialists do the slow thawing. So what happened in rapid freezing? It leads to the destruction of cell membrane, and leading to the formation of ice crystals. And when the rapid thawing process will occur, it will lead to the microcirculatory failure and led to the cellular anoxia. Now, this whole process, the initial phase is that it usually create a hyperosmotic extracellular environment for the cell. During initial phase, the freezing phase, a hypertonic extracellular environment is formed. So during this same freezing phase, when it is achieved and this thawing phase is arrived, this thawing phase will lead to intracellular anoxia. Microcirculatory failure will occur. The circulation is blocked, but up to a limited extent. This microcirculatory failure will lead to the formation of cytotoxic species that led to the further disruptions of the membrane intracellular organelles and ultimately cellular anoxia. Cell will end up in anaerobic metabolism and ultimately it will die. So this is basically the pathophysiology by which cryoablation works.
And the applicators initially developed for cryoablations were relatively large, and laparoscopy was required. Nowadays, smaller probes are available, enabling percutaneous image guidance ablation. During cryoablation, the ice ball can be visualized in real time with either CT or MRI, which allow the extent of cell death to be more reliably predicted.
This is one of the indication I was talking about before, that in radio frequency ablation, the generation of heat is up till extent that it is very difficult to monitor with the help of this imaging technique. But this ice ball formation can be detected using a special microtransducer probes of the ultrasound. And it's very, literature says that it's comparatively easy for those who are expertise in this field to detect this ice ball formation so that surrounding organs cannot be injured. This is the main reason that cryosurgery is much more in and much more studied as compared to radio frequency ablation.
And the complete cell death is thought to occur 3 mm inside the edge of the ice ball. Thus, most operators extend the ice ball at least 5 mm beyond the tumor margin to ensure complete tumor coverage. Now, this is again the pictorial representation of the CT-guided cryoablation. And the image A, we can appreciate a renal tumor. And the image B and on other further images where 2 to 3 cryoablation probes are introduced into the tumors. And in the last image, image E, where you can appreciate an ice ball that is represented by a hypodense area in the tumor with the 3 probes in situ. And this is a coronal image where you can appreciate the 3 probes going into the tumor and the ice ball. Now we will see a short video.
Cryoablation of the kidney tumors is a minimally invasive procedure performed under image guidance, such as CT scan. It is most often performed by an interventional radiologist in an outpatient setting. The patient lies on the procedure table. The initial CT images are obtained. The location of the tumor in the kidney is determined, and the cryoablation antennae entry site is marked on the skin. Then, the access site is sterilized. The access area is covered by a surgical drape. The skin and renal capsule are numbed with a local anesthetic at the access site. A very small nick may be made in your skin to make it easier to pass the antenna into the kidney tumor. Then, the tip of cryoablation antenna is placed within the kidney tumor under CT guidance. The alternative phases of freeze and thaw are then applied per interventionist preference. Each cryoablation at least takes about 30 minutes. At the end of the procedure, the antenna is removed, pressure is applied, and dressing is placed at the access site on the skin.
So it's same as radiofrequency ablation. The procedure is same, but the material used are different. Any questions? Any points till now? No. Proceed, Vikalpa.
Thank you. Moving towards microwave ablation. Microwave ablation also use heat for the ablations, and in contrast to radiofrequency ablation, a microwave incorporates an antenna to receive externally applied energy at 930 to 2450 megahertz. That is far more higher in the radiofrequency ablation. This microwave energy results in the rotation of polar molecules that is opposed by frictional force, which is then converted to the heat. And these techniques are increasingly popular for ablation of the liver and lung tumors, but data for use of RCC are still limited. One meta-analysis comparing microwave ablation with cryoablation showed that both were effective and results in similar efficacy. That is 93.8 versus 91.3%. And the cancer-specific survival is 98.3 versus 96.8% respectively. A potential advantage of microwave ablation over RFA is greater energy deposition, particularly when tissue evaporation occurs, and thus the development of higher temperatures. The high energy may also be more resilient to heat sink effect, which can be an important obstacle for radiofrequency ablation. Now, the other emerging therapies are stereotactic ablative body radiotherapy, which is a highly focused radiation therapy, which gives an intense radiation, and it is to the localized tumor with a minimal impact to the surrounding tissue. And this stereotactic ablative body radiotherapy is also very highly effective and with a greater accuracy. And each session takes around half an hour to 1 hour, and it lasts for around 1 to 5 days, and it can be done as outpatient settings and spars the surrounding tissue. So it is nowadays increasingly popular. And the other technique is irreversible electroporation. In this technique, a focal micro to millisecond electrical pulse by a thin needle is delivered to induce cell death by disrupting the cell membrane. Unlike other techniques like radiofrequency and microwave, heat is not necessary. So it has these advantages, and it can be used in certain locations, and it has a protective effect in blood vessels, bile ducts, and knobs. And this could make this technology better for central tumors as well, where there is a risk of damage to the collecting system. Now, the surveillance after ablation. CT or MRI is typically used to assess the success of the tumor ablation, starting approximately 1 month after treatment. On the CT, if the tumor has an enhancement more than 10 Hounsfield unit after contrast injection, then it is a viable tumor. Whereas the ablated tumors no longer enhances with contrast. The imaging immediately following the ablation is difficult to interpret because of the inflammation at the periphery of the lesion that can mimic a viable tumor. Thus, the post-treatment CT imaging is usually performed at 3 to 6 months, 12 months, 18 months, and 24 months after ablation, and yearly thereafter.
These are basically the guidelines from individual institution. There is no such specified guidelines about the post-op follow-up for these recommended techniques, whether we have to do biopsy. Book says that 3 to 6 monthly surveillance is very much necessary. Some literature says that yearly surveillance is very much necessary. It depends upon the initial tumor size, initial tumor mass, whether the procedure was successful or not. So it depends from institution to institution. Every institution makes its own guideline in this regard. Yes.
And the outcomes, multiple series have reported excellent short-term disease control with radiofrequency ablation, cryoablation, and microwave ablation. The result appears comparable to those with partial nephrectomy or radical nephrectomy, and both techniques appear to be well tolerated with a low incidence of serious complications. And the more limited long-term outcomes in the non-surgical patients are also encouraging. Now, the side effects or drawbacks, some patient has a self-limited syndrome manifested by a fever and flu-like symptoms have been reported in up to 1/3 of the patient following this therapy, and the patient may need a repeated imaging follow-ups later and may need multiple ablation session. These are the drawbacks. Now, the radiofrequency versus cryoablation. There are no randomized control trials that compared RFA with cryoablation in the management of RCC. The results with these two approaches were compared in a meta-analysis that included 47 series and consisted of patients with a sporadic and localized RCC. Local tumor progression after a single treatment session was more frequent after radiofrequency ablation, that is 12.9 versus 5.2% with cryoablation. And the repeated ablation therapy was required more often following initial treatment with RFA, that is 8.5 versus 1.3%. And these differences were statistically significant. However, numerous retrospective series have been published which do give some insight into the outcomes with these approaches. However, any real differences between cryoablation and radiofrequency ablation is likely very small. Now, both these techniques are effective and preserve renal functions after treatment, with most studies demonstrating no significant decline in renal function.
Again, decline in renal function depends upon the preoperative status of the kidney, the comorbidities, the tumor size. Okay. Yes, Vikalpa.
Now, the summary of the evidence. Low quality study suggests higher disease recurrence rate after radiofrequency ablation of tumor more than 3 cm and after cryoablation of tumor more than 4 cm, which has a level of evidence 3. And the low quality study suggests a high local recurrence rate for thermal ablation therapies compared to partial nephrectomy. But quality of data does not allow definitive conclusions, which has also a level of evidence 3. Now, the recommendations: offer active surveillance or thermal ablations to frail or comorbid patient with small renal mass, which has weak strength rating. Perform percutaneous renal mass biopsy prior to and not concomitantly with thermal ablations, which has a strong strength rating. When thermal ablation or active surveillance is offered, always discuss with the patient about the harms or benefit with regard to oncological outcomes and complications, which has a strong strength rating. And do not routinely offer thermal ablation for tumors more than 3 cm and cryoablation for tumor more than 4 cm, which has a weak strength rating. Thank you.